If you're considering all-on-4 dental implants, here's a terrifying reality. Most dentists don't understand proper bite mechanics, but you won't know something's wrong until you get your new teeth because your bite will feel completely off. But by then, it's too late. Today, our prosthodontists at North Texas Dental Surgery are exposing the widespread problem of improper bite setup in all-on-4 cases. You'll learn the warning signs that your bite is wrong, why that off feeling in your mouth is actually predicting future catastrophic failure, and the sophisticated science of occlusion that most dental practices completely skip. We'll reveal why losing your natural teeth means losing your jaw's GPS system and how this leads to the uncomfortable, unnatural feeling so many all-on-4 patients experience. And don't miss the shocking patient stories, including a lifelong grinder whose all-on-4 seemed perfect until screws started breaking, and why that uncomfortable feeling most patients ignore is actually the early warning sign of impending failure. With 90 to 95% of dentists getting bite positioning wrong, this video could save you from years of problems and expensive revisions. So we touched about this a little bit earlier, but why is proper occlusion, meaning the patient's bite, why is it so critical and what makes it complex?
What that means is it's not just static occlusion, right? Most of the places when you see, it's just they take into account that the patient is biting down and the bite is perfected with the biting down. I think what's equally important is like the dynamic aspect of it. Because when you're chewing, you're not just chewing tap, tap, tap. Right?
I used to say that those those Halloween toys where like the teeth are like, that's not a bite.
That's not at all the bite.
Yeah.
And your jaw never closes in one dimension. Jaw actually slides out and then closes in an arc, right? So I think, and that arc is very custom to every patient. So I think taking into account those eccentric movements where the patient, eccentric just means that essentially patient slides left and slides right and slides forward. So essentially these three big movements, we kind of design the bite so that patient can do that in a more balanced and harmonious way. Because anytime the patient does any of these movements in a way that's, they have what we call an interference, which is just like when they hit something prematurely, that's a lot of force concentrated onto that one tooth or that one area.
Right.
And if you repeat that over years or over months, what happens is you have some kind of failure. Like that patient we were just talking about where, we had failure in a couple of years. Occlusion was the number one factor because she was biting only on the back teeth, especially when she slid forward. So it was interesting that she wasn't biting on those teeth when she was biting down, tap, tap, tap. But when she was chewing, she was hitting, and we saw that with the fracture of those back teeth.
Right.
So the old fillings were fractured off. There were signs of wear that we saw on the teeth.
Right.
So I think seeing those things when the patient presents helps us in kind of designing the bite of where teeth should be.
Right. So what was critical about that case was exactly like there were interferences, but also coupling that with implants that weren't, placed properly. They could have definitely placed longer implants and wider implants, giving more surface area of that implant to bone, the bone implant contact. But then you couple that with the occlusion being off. That was that eventually that all-on-4 solution. And it was frustrating for her because I was talking to her and she was like, man, I had these issues and I was missing a few teeth and I didn't have to go to an all-on-4, but I decided to go to an all-on-4 because I thought that it was going to last a lot longer than this, right? And so nothing is more frustrating for a patient than being in that situation. What are your thoughts about that, the occlusion?
Occlusion plays a very important role in any kind of like full mouth rehab, either in implant or teeth. And I like to talk about occlusion, about giving patient freedom to function where they want. Because like as Dr. Said was saying, occlusion is not static on one position.
So there's not an ideal occlusion for a person. It's almost like you can think what something may be ideal, but then you have to try it out on that patient, right?
Yeah, you start with what you think is like best for the patient, which normally is what we call like more like forces on the back teeth, the front teeth, or implant a little bit more like relieved. And then you have to see how the patient just by seeing the patient, asking the patient to bite down, you can see how they're biting down in terms that the bite, it doesn't depend on the teeth, but it depends on the muscles, on the joint, on the neurological system of the patient, you know what I mean? Because patients bite differently if they're conscious or unconscious. So that's when we talk about, as prosthodontists, sometimes we manipulate the patient's jaw into a position in which we think that's the position where the patient functions when they're like not thinking about it. Let's say, are you thinking about how you're biting down when you eat? No. And are you thinking about your teeth when you're talking? No. And even less when you're grinding at night. You know what I mean? So it's important, in my opinion, to give freedom to the patient to feel comfortable with their occlusion, and to, very important, as Dr. Said said, to look at the dynamics, which means that when the patient goes towards the right side or towards the left side or front, or sometimes biting down, or give the patient like a chewing gum to bite down. And then there's when you notice like, oh, there's an interference there. There's something contacting that it shouldn't, and I would have noticed unless I give a patient a chewing gum. You know what I mean?
And I think one more thing is that I would add is like, adaptability. I think a lot of patients that present to us have some kind of parafunction or like, TMD. And
can you explain what parafunction is?
Parafunction is just like, so when you're functioning normally, that's function. But parafunction is any abnormal function that you're doing unknowingly. So when at night, like let's say if you're bruxing, which means if you're grinding your teeth together, or in times of stress, if you're clenching, these are parafunctional habits. These are obviously a no-no when we don't want to have any of that, because all of that can be unaccounted for completely. Like whatever bite we plan, if patient is grinding their teeth at night, there's no way to keep that into account, because patient is completely unconscious. We don't know how much they're moving their jaw to the left or to the right, and so it's very hard to account for, which is why we put our patients in a night guard when they are there. And what I was saying is that, I think it's important to test the bite out, and we give the patient time to adapt to it. And we see, patient comes back in a couple of weeks, tells us that, I feel, and we see that if they can get back to the same point that we're designing their bite. If they can, good. If they can't, then we have to kind of go back to the drawing board and kind of see where to get the patient to, so that the patient's comfortable, patient can function, and obviously patient's happy then.
Let's talk about centric relation. Can we talk about in patient-friendly terms so that patients can really understand what is centric relation and why they should be like concerned about it, why they should be aware of it? So
yeah,
could you tell me more about that?
So centric relation is just essentially a relationship between, to make it very simple, like when you lose your teeth, right? Because we're going to talk in All-on-X terms, All-on-4 terms. When patients lose their teeth, they lose the supporting structure. Every tooth has a ligament inside it. So that ligament actually has nerve endings inside it. And those nerve endings actually get compressed and give the signal to the brain when the patient bites down. So they actually act almost as GPS coordinates to tell the jaw, okay, so this is my home base. This is where I have to get to. When you lose the teeth, you lose those nerve endings. Yeah. So you kind of lose reality of where your bite should be. So we see that, especially patients with complete dentures, they kind of lose where, to guide. So we have to kind of program their bite into what we want them to be at. So that's what centric relation is. We are not, because we've lost the teeth.
So the home base.
Exactly, it's the home base. So we're establishing a home base. We want that home base to be repeatable. We want it to be reproducible, and we want it to feel natural. And obviously we want it to be pathology free, which means that we don't want any kind of jaw pain or muscle pain when the patient is in that position. And I think with All-on-X, we just like any other treatment modality, when you lose teeth, patients lose that kind of feedback almost that their body feels that when they're biting down into food and functioning.
And so one other thing to add, I like to add about that is centric relation is not that simple, because the other issue is that not everybody's coming in within, again, as I was saying earlier, the ideal case would be somebody who just has extensive amount of decay, and the best thing for that patient, their best solution would be to get a full arch type of solution, All-on-4. But what about that patient who's had been missing their teeth for many years, had bone loss also, decreased VDO, or that patient who's had their teeth kind of splaying out from periodontal disease, right? They don't even remember what their ideal natural bite is, right? So what are your thoughts about that? Do you find cases like that to be more difficult, or I know you guys prosthodontists are the experts, but or do you find getting that patient in CR is pretty easy?
It's a fact that I would say 90 to 95% of human beings, where our bite is, like my bite, it's not my CR. Okay. And that's okay. If 90 to 95% of human beings are like that, then it means that that's fine. Mm-hmm. The problem comes when we're going to restore a patient. Because when we're going to restore a patient in All-on-4 and All-on-6 or crowns or whatever we're placing something in their mouth, which is like a prosthesis or a crown or a material, that it's something that it's not given by God. It's not natural. So how I think about it is normally in most of the cases, if this is the upper jaw and this is the bottom jaw, this is where we're batting down. Let's say if we take out these teeth, this might be the patient's CR. Normally in most of the cases, like more backwards, more posterior than normal bite. Mm-hmm. Most of human beings, we have this is called like CR/CO discrepancy, right. and that's fine, which means that where centric relation is to where our bite is, it's different, and that's fine. For me, the major concern is most of us, we're always biting down there, except when we're like unconscious or asleep, that we might bite down here. Okay. On our natural teeth, that's fine because we have like a lot of mechanisms like enamel, dentin, or the periodontal ligament that give us that leeway. What happens, the teeth wear. Okay. But if we're restricting the patient with porcelain, let's say, or zirconia, what might happen is material fracture, or if it's zirconia and the zirconia doesn't fracture, what can happen? Maybe screw loosening, right, or screw fracture. Right. So my point is that for me, the importance of centric relation, is having a position in which when the patient is like in a relaxed position unconsciously, it's where the teeth meet. Because if that's not that position, then the patient is gonna go here and then it's gonna slide forward. Right. And that slide, for me, it's important due to the possibility of the material fracture. Right. Same as I told you, orthodontic treatment. You know what I mean? Like the main reason, in my opinion, for relapse, so many patients are like, oh, I had braces or Invisalign a few years ago, my teeth are back. It's because if those braces or that Invisalign is done here instead of here, then when the patient bites down unconsciously or the first moment of the day without like thinking about it, they're not used to it, they bite down here, then they slide, and that means that the teeth move again. Right. So I think that's the main issue.
So if I can understand you here, basically the gist of what you're talking about is not being in CR with your final prosthesis is not that big of a deal. However, because your natural teeth and dentition, you have your enamel, which you could wear through, you have your dentin, you have your periodontal ligament. These are all biomechanical factors that have some give. Yeah. However, once you head into a zirconia set of teeth and you're not in centric relation, and if you experience some parafunction or you're doing things like, unconsciously, then things are always going to fail at the weakest part. And what we know about zirconia, actually a lot of people don't know about zirconia, but I was watching that lecture about zirconia implants a few weeks ago, but then they were briefly talking about zirconia prostheses, right? Individual crowns, and they were talking about, hey, the mechanical properties start changing in a warm and humid environment, right? That can change its crystalline structure, could cause it to fracture easier. And so what is going to be the weakest interface? It could be the zirconia over time. Well, we can compensate for that because we're going to have to put that patient in a night guard. But then there's something underneath that. There's the prosthetic screw that's screwing the teeth into the multi-unit abutment. And then what's securing that multi-unit abutment into the dental implant? There's a prosthetic screw, right? We had a patient not too long ago, and this guy is a lifelong grinder. He did an All-on-4, works out great, but a few years later, he comes in with a fractured abutment, right? And so things are always gonna suffer at the weakest interface. So am I hearing you right in regards to that?